Hi, everybody. Welcome. My name is Jennifer Griffith, and I work at the Northeast Waste Management Officials Association, otherwise known as NEWMOA. We're an interstate association. The 6 New England states, New York and New Jersey, work together through NEWMOA on different waste-related topics. So solid waste, hazardous waste, pollution prevention and toxic use reduction, those sort of topics, and also the waste site cleanup programs. And I manage the waste site cleanup program at NEWMOA, and one of the main items that the states want NEWMOA to help them with in the waste site cleanup area is training. So that's what we're doing here today. So we've got a great presenter and topic. We're talking about risk communication on PFAS and PFAS issues. And I will introduce Claire in a minute, but I wanted to just let you know this is the NEWMOA website. Claire, are you seeing the NEWMOA website?
Yes, I am.
Okay, and so you can find out a lot more information here, but this presentation will get posted on the website. So I'm just going to show you how to find it, and then also you can see where other resources are. So if you click events, then here's all the upcoming events. So we've got different things that are open to the public that are coming up that you can see. And here's today's webinar. Now, pretty soon, today's webinar is going to be in the past. So this website does everything very forward-looking. So here's all the future things. If you want to look at past things, you got to know about this little arrow back here. Click that little arrow, and then you end up in the past. So, and then the most recent past will be at the bottom. So it'll keep moving. But anyway, there's 3 webinars that we've done so far in this PFAS series. There's going to be 12 total, and today's number 4. So we did one on forensics just last week, emerging issues, and then also some basics. So that's where you'll be able to find information about today's webinar, and the presentation will get posted. I will send an email to everybody that's here when it is posted, though. We've got lots of people joining us today, so if you have questions, you're going to need to type them in. You can type them into the, your GoToWebinar control panel has a questions section. You can type them in at any point. I'll be asking the questions of Claire later, but you can type them in at any point. Also new with this webinar series is NEWMOA is getting being able to offer continuing education credits for Massachusetts licensed site professionals. So we're just doing the certificates for Massachusetts licensed site professionals. But if you are a Massachusetts licensed site professional and you do want credit for this webinar, there's a couple things you have to do. You need to stay on till the end. And this is just educational for everybody. I don't know if you know, but GoToWebinar can tell if you're doing something else on your computer. They can tell when the webinar itself is not the topmost layer of your computer. So if you want those LSP credits, you have to keep this as the top layer. That we are going to have some poll questions during the webinar, and you're going to need to have to be able to answer them all. And then also, if you are wanting the LSP credits, you need to ask at least one question. So you're going to have to type in at least one question, hopefully a relevant question, during the webinar. And then most importantly, if you want the credits, you need to email me afterwards so that I know that you want them, because otherwise I don't know. So I think with that, I'm pretty much done with what I need to say. We are going to post the presentations again on the NEWMOA website, and we are going to, you're going to need to type in questions when you have them. So with that, I'm going to turn it over to Claire. So Claire Nitsche is the Environmental Health Educator for the State of Washington Department of Health, and she specializes in PFAS and communication. Using her skill set in applied behavior change theory, health communication, psychology, anthropology, and environmental health literacy applications, she works hand in hand with community advocates and Department of Health toxicologists to ensure that Department of Health's PFAS education materials are accessible, understandable, and actionable and balance the lived experience of community members with this rapidly developing science. She's got a lot of interesting experience, including being the English language and environmental health educator for trekking and mountaineering guides at the Kathmandu, Nepal, in Nepal, environmental education project. She's a master's certified health education specialist and has a master's of public health in global health and health disparities from the Colorado School of Public Health. So with that, I'm going to mute myself and turn off my camera, and Claire can take it over. So thank you so much.
All right, thank you so much for that introduction, Jennifer. Just as I'm getting started, because I'm still learning this, can you see my screen right now?
I can, but it's not in slideshow mode. So.
Okay, so let me go ahead and put it in slideshow mode and turn off my camera. All right, can you see it in slideshow? Are you seeing my presenter view or are you seeing the actual slide?
Yeah, now we're seeing the presenter view. So you just need to go to the display settings and duplicate the slideshow, or I don't know if you know a different way to do it, but that's the way I always do it.
Let me just go ahead and switch things up really quick. Display settings. All right, how's that?
Now it looks great.
Okay, fantastic. Well, thank you so much, everyone, for taking time out of your afternoon to join me today. We're going to be talking about how to be less governmenty, and we'll be covering community-centered PFAS risk communication in Washington State. So as Jennifer just said, my name is Claire Nitsche. I won't reintroduce myself, but I am the PFAS Health Educator for Washington State Department of Health. I have been here since August 2022, so just celebrated 2 years. And I have been leading our efforts to build our PFAS health education program from the ground up. And I work hand in hand with our toxicologist, Barb Morrissey. So I do want to acknowledge that while I'm going to be talking about a lot of different work that we've done as a team here at DOH over the last 2 years, we by no means have done this alone. PFAS is a difficult issue, and while one person climbs a mountain, teams move them. And so by no means have we done any of this alone, because it really has taken a team. So wanted to give a shout out to everybody we've worked with for the last 2 years, and especially call out our 2 community groups, Pursue PFAS Free and the West Plains Water Coalition, and thank them for their collaboration and partnership. So we're going to be starting here with a group activity, and yes, that is an example of some rudimentary yet effective PFAS risk communication, and this is just to get our heads rolling on what we're talking about today. So Jennifer will be putting this in the poll, but I want you to answer this question with your best guess. According to the CDC, what percentage of adults in the United States can find, understand, and use health information to make informed health decisions? 50%, 70%, 10%, or 25%? And go ahead and put in your absolute best guess. Give you guys a couple of seconds to get that done.
Yes, they're coming in. A lot of people have voted. We'll just let another few minutes. I mean, not few minutes, few seconds. I'm gonna close it. We're just at 90% there. 91% voted. Okay,
all right. So our answer is 10%. Recent data from the CDC shows that 90% of Americans do not have adequate health literacy, which is the ability to find, understand, and use health information to make informed health decisions. For navigating healthcare and making health decisions, that is a huge number of people. So for our second question, this is a true-false question. People with good health literacy are also able to find, understand, and use environmental health information to make informed health decisions. True or false?
Okay, people are voting. We're getting there, close to 90%. We'll just wait till we get a little over 90. All right, I'm going to close this one.
All right, the answer is false. Studies show that traditional health literacy, what we just discussed, does not translate or predict environmental health literacy. And we'll go over in a couple of slides what environmental health literacy is. But if we know that 90% of Americans don't have the adequate health literacy to be able to make informed health decisions about their basic health, less than that have the ability to make informed decisions about environmental health impacts, which is a very big problem when we're dealing with PFAS risk communication. All right, in our third activity, before we get rolling on the rest of the presentation, people with college degrees are better able to understand health numbers and what they mean, and that is what they mean in context that they're given. True or false?
Okay, yeah, this one is people are a little more split on their answers here. So let's see. We'll let a few more people vote. It's like an election or something where it's close. It's close. Okay, we'll let one or two more. Oh no. Okay, I'm going to close this one.
All right, and that answer is false. Recent studies from the CDC show that only 10% of Americans, 10%, even those with advanced college degrees, understand health numbers and what they mean in context. 90% of Americans struggle with this, even if they have a college degree. And with that, we're going to go into health education and touch on environmental health literacy. Now, I want to be aware that, talking to my friends in the Northeast, we might not all be coming from a public health background. So I wanted to introduce the 10 essential public health services. And these are the foundation of public health practice at the local, state, and federal level. And they're incredibly important because they make up our day-to-day activities. They are the foundation of the programs we run, and it's all centered around equity. And I want to call out that, communicate effectively to inform and educate is one of these 10 essential public health services. And in my 7 years of working on public health related projects, either in the nonprofit world or here at the state, I found that above and beyond communicating effectively to inform and educate is the biggest stumbling block we have as professionals in public health. Which is why here at DOH, we're using a discipline called health education to address that component of the 10 essential public health services. So health education as a discipline focuses on health literacy applications, communication psychology, learning psychology, behavior change theory, anthropology and sociology for myself as an anthropologist, social marketing, risk communication, and much more to target health literacy and improve health outcomes. So health education is the tool that we are using in the discipline to be able to start addressing some of these issues that we're seeing. Now, earlier I introduced environmental health literacy, and that's a key component that we're targeting when we're doing environmental health education. Now, the definition of environmental health literacy is still being debated by practitioners because it's relatively new in our understanding. But the two that I find the most clear are the ability to understand the connections between environmental exposures and human health, and the ability to seek out and comprehend information about environmental health issues and to make informed decisions based on that information to reduce health risks, improve quality of life, and protect the environment. So it's the understanding what's happening in the environment, understanding how the environment connects to our personal health, knowing where to find resources about the environmental health issue, knowing how and why to act to protect ourselves against that issue. Now, I want to focus on the word act, because act is a really key component to this. And act is itself has a lot of different barriers that go beyond just having the information. It requires self-efficacy and collective efficacy, which is the feeling of an entire group that the action will actually bring a solution, feeling confident in whatever that solution is, that it actually is going to work. Access to resources, the list goes on and on and on. So while we might say act as a simple 3-letter word, it is actually one of the most complicated aspects of doing any form of PFAS risk communication. Additionally, science is just hard to communicate in a way that makes people care and drive action. And I think we've all experienced this as professionals. And from the perspective of a health educator, specific issues that we're running into with PFAS health education and risk communication is a lack of accessible, understandable, specific, and actionable information. And that's a barrier to health equity. Health literacy itself is also what's known as a social determinant of health, which are the non-medical factors that significantly influence and impact health outcomes. And studies suggest that these social determinants of health account for at least 30 to 55 of our health outcomes. That's the most recent number I saw from the World Health Organization. Additionally, we run into one of my favorite psychological terms, which is that humans are known as cognitive misers. This means that we subconsciously problem solve in the most simple, straightforward way versus a more time-intensive, effort-intensive ways. This is a survival thing, and it helps us conserve energy. And this is the best description I have of it is that if we're walking through the woods and our good friend the bear jumps out of a bush and starts chasing us, we're not going to sit there and do critical thinking of, is it better for me to use my bear spray? Is it better for me to climb a tree? Is it better for me to come at it with a stick? Or is it better for me to just run faster than my friend? We are going to automatically in our brains go to solve something in the most simple, straightforward way so that we can convert that energy instead into doing whatever it is to keep us safe or whatever task we need to do based off of what we have at hand. Plain talking, which is a really common tool I see used, helps, but it's not enough alone because it's subjective to an author's definition of what common language is. And that can often be the language, a simplified version of the language they use most often with their peers. And that's important because we know from studies that information alone is not enough to make people care about an issue or change behaviors. Now, before we roll on to the next section of the presentation, I do need to emphasize that when we're talking about health education, that term is not interchangeable with outreach. These are two separate things, but I see them get mixed up regularly. So when we say the term outreach, the goal of outreach is to raise awareness for a topic in the context of the presentation today. Outreach provides additional information about projects or programs going on in an agency. It's usually, from what I've seen, a one-way street, saying, hey, we have these resources, we have these programs, this is what we are doing. And sometimes that outreach is statutorily required. Health education, as we've talked about, the goal is to support and improve health outcomes by increasing health literacy. That requires a two-way street of communication because health education is building data and theory-based programs and resources that are centered around a community's health needs. And it's hard to know what those health needs are without talking to people. We're using behavior change science and social marketing, and outreach is just one tool in that health education toolkit, and it's important, but it's by no means the entire thing. And from there, I'm going to start talking about how we're building our foundation for PFAS health education using these concepts. Now, all of us as risk communicators know that one of the cornerstones of good risk communication is knowing who your audience is, and that's important because there is no such thing as the general public. Next time you're in a room, I invite you to look around and just notice how many different demographic groups are there. It could be age groups, it could be, maybe political affiliation, it could be ethnicity, it could be culture, it could be any of these things that we're looking at, that every single person has a slightly different background and therefore is going to have a different worldview. I like to say there's 8 billion different worldviews and ways to be human on the face of the planet. And we need that tailored messaging for messaging to be effective and connect with people. So when we say, oh, well, we're just doing general public messaging, my question back to you is who? And when I started with DOH in August 2022, we needed to figure out who our audience was in order to start building an effective health education program for PFAS. And what we came up with was communities who were acutely impacted by PFAS in drinking water. I work predominantly with private wells. I've dabbled a little bit in the water system world, but I very much am not a part of that. And we also had Washingtonians who were passively impacted by PFAS in their day-to-day lives. And that could be through consumer products, it could be through the food that they were eating, it could be a various amount of things, but either way, it's people who didn't necessarily have the exposure acutely in their drinking water. Now, both of these groups are going to require tailored messaging, and both of these groups we can suspect from data will probably need some environmental health literacy support. But each of these groups is going to need a different approach in order for us to be able to make sure that our risk communication is effective. We're going to start with acutely impacted communities and how we handle that. So if you attended my presentation at the Northeast PFAS conference in April in Marlborough, you've heard the story, but it's the premise of it is that the single biggest problem in communication is the illusion that it has taken place. Now, when I started in August 2022, I was informed that I would be going to a community meeting in September. That community meeting was taking place in a town called East Selah, which if you're not familiar with Washington, it's just over our Cascade Mountains in kind of the central area. And it's a very, very rural town. And that rural town backs up to a military installment. And I learned that we had about 800 different homes that were impacted by suspected AFFF contamination of private well water coming from that military base. And our military partners had they had done a town hall, and they had also run another poster session, and I would be attending another poster session. And so me and the team got in the car, and we had all of our health risk communication materials. We had a new fact sheet on point of use water filters, and we met with our partners, and we ultimately ended up interacting with 200 different people. So by that number, it was a success. We got to give our message out to a lot of people. We engaged the community. But while we were there, we found out that our military partner, when they had been giving out their results, had told people that were below 70 parts per trillion combined PFOA PFAS that no further action was needed. And this was before the EPA MCLs came out. And our state had different health advice. We had state action levels for 5 different PFAS that were significantly lower. And so we went, oh my gosh, how many people have not been attending these meetings that are still being exposed and aren't getting information about our health risks? And so Barb, our toxicologist, looked at me and said, Claire, I need a two-way street of communication with this community stat. What can you do for me? Well, around that same time, my phone rang, and I got a call from a community advocate that I met at the meeting named Brandy. And Brandy started talking, and then she stopped and she went, wait, hang on. Who am I talking to again? You're the first person at DOH I've actually been able to reach on the phone. And I went, Houston, we have 2 problems, because one, if this community is only seeing us when we come in person and they don't know how to access the resources that DOH has, we have a problem. And the more I talked to Brandy, the more I learned that her questions about PFAS and steps that she could take in her day-to-day life were still not being answered. So despite checking every single box that we did everything right with community engagement, we still had some big risk communication gaps that we needed to address. So the original model that we were using that wasn't successful for community engagement was this open house meeting. It was a poster session. Poster sessions, they always have a set of topic stations with subject matter experts at each station. Those are typically posters or tables. Agencies anticipate what the main questions will be during that meeting planning, but they don't always talk to community members ahead of time about what their questions will be. This can skew the meeting towards what agencies want to talk about instead of what the community members want and need to know, which means that our intent and our impact can be misaligned. Community members flow through between the stations, which means that there's an emphasis on explaining that poster and answering questions through one-on-one conversations, which helps agencies handle large groups of people and keep meetings on track while answering questions, which the positive of it is that it can allow community members to drop in so people can be on their own schedule and learn about their own interests. But we knew from talking with our community advocate that this just was not actually meeting the needs that people needed to have addressed. So getting on a call with Brandy, we decided, okay, with both the needs of our toxicologist to give out health information and also the needs of the community, we should probably have a community meeting again. But we need to figure out what the actual needs are. And so we looked at perceived needs, which are a need defined by what people think or feel their needs are, and the expressed needs, which are a need defined by the number of people who've sought help. And what we came up with were these 4 components. So we had environmental health literacy, what PFAS are, the health impacts, our state's health advice on PFAS in drinking water. People needed to have their most pressing questions answered by experts in an understandable, action-centered way. People also needed some help developing some stronger government literacy about the situation. They needed access to their agency representatives, their civil servants, and an understanding of how we all fit together or how we don't, and what government systems may be in place to help them. And really importantly, people really needed to be heard. When PFAS get into the drinking water of an agricultural community, as we know, it has the power to upend lives because it is in every aspect of your day-to-day being. And people really needed to come together as a community and have their stories and needs heard, because when we're addressing health, we can't just address the, oh, you know, we're concerned about decreased immune response to vaccines, we're concerned about kidney cancer, we're concerned about higher cholesterol. There's a psychological aspect to health that we need to be addressing, and giving people a space to tell their stories is part of that. People also needed agency in decision making. They were being treated like a stakeholder, which meant that they were being told what the solutions they were going to get were, but weren't part of the solution, of the decision making on those solutions, which is a problem because we know from environmental justice studies that the people who are closest to the solution are also, or people who are closest to the problem are also closest to the solution. And people needed, this community needed to be put back in the driver's seat and made sure that they have a permanent seat at that decision table going forward. So my job as a health educator is to say, okay, everything I'm doing also has to be data-based. So I looked at what we had as far as our needs went and went, I don't have a model in risk communication and community engagement and behavior change that alone is going to fit the situation. And so I knew we needed to develop something new. So I went into the literature and I pulled 7 different behavior change theories and applications from psychological first aid and also vaccine hesitancy, and created a model for how we could do community engagement and risk communication at this meeting, and then took that back to our community partner and our agency partners at the local, state, and federal level and said, okay, this is what we've got, this is how I think we should do it. And we fine-tuned that model and started planning logistics for a session. And we ended up running that session, the very first pilot, in February of 2023. And it was called a community listening session. And the goal was to center community voices. And I do want to give a quick note here. This is different than ATSDR's listening sessions. This was a name that was decided on by Brandy, our community advocate, because she felt that it would resonate the best with her neighbors. And she also felt like it was going to be the best verbiage to show that this was something that was going to be very different than what this community had received. So we had 100 people, over 100 people show up into news stations, which is where you're seeing the clip from that particular session. Now, what did we actually do? What's the theory applied here? So as I mentioned, this was built for an audience of 100+ people. We needed it to be open to the public, but targeted to impacted community members and make sure that everyone felt welcome. And we also knew that we're dealing with a rural community who does not inherently trust the government and has been having some pretty rough issues to this point. And so we needed to make this a true community-centered meeting. This meant that we had Brandy as our community advocate open and close the meeting. She introduced myself, I introduced our panelists, but she was our first and last voice. They had the mic from start to finish. All of the panelists were introduced as invited guests. The community got, Brandy and her team got to decide who actually got to sit on the panel, and we could make recommendations to them and help extend invites. But ultimately, if there was a group that they really weren't comfortable with, then we listened to that and made sure that we only had the representatives from the different agencies that they were really needing to talk to that we could get there, and also who they felt like they could trust and actually have a conversation with based off their current relationship. And if you'll notice from that, from the invite, we also had no agency logos on that invite. It was true community centered. We advertised this by going, our local health partners helped us with this. There were handouts that Brandy took around to her neighbors. There's one road in and out of East Sela, and so there was a giant road sign that just said community listening session, PFAS, this date, show up. And that's how we got 100 people. The other thing we did is that we flipped the meeting. We had a PFAS basics lesson ahead of time at Brandy's request, but ultimately we said, no, we need this to be truly the communities in the driver's seat. So we asked the community 3 questions. The first was, what questions do you still have unanswered? What would you like to work on together going forward? And what else do you need us to know? Now, an important component is meeting people where they're at. Sometimes they didn't know how to ask their questions, and we needed to be prepared for that. So whenever somebody would speak up, myself as the moderator, as the health educator, we would repeat that question back to that community member to make sure that we got it correctly. And that was important because our #1 priority was making sure that community members felt heard. We also, as the moderator, we plain talked answers in real time. That way, it wasn't a burden on our community members, especially in front of a crowd, to say, hey, I don't really understand that, which can be really socially uncomfortable. And so as the health educator, I could say, I'll pick on Barb here. Hey, Barb, I don't know what remediation means. Can you tell me a little bit more about that or explain a little bit more what you meant there? And I could pick up on words that I know have been stumbling blocks in the past, or I could be watching body language with our community members in the audience and be like, okay, I think we just missed there. Let's go back and revisit that. And that way I could have the burden of being the one that could say, I'm not entirely sure what that means. We also offered multiple ways to ask questions. People could either speak up or they could write anonymously on a note card that was brought up to me or put into a box. And they could also email or call after the meeting. We made sure everybody had the business cards of both myself or whatever panelists were comfortable giving out that business card. And importantly, we set our panelists at the same height as the audience. There was no stage, there was no podium. We were meeting them as equals on the exact same ground. And that's important because communication is holistic. It is not just words, it's also our actions and our cues and the environment that we set up whenever we are doing any form of risk communication. So this was how we actually chose to set up the room, and it was deliberate. We had visible note takers to show people that we were accountable to what they were saying, and we let them know we'd be making a report that we'd give back to them that would include the actions we were taking based off of what they shared with us. Myself as the moderator, I could float between our agency representatives and our community members as needed, and so could our community advocate, who we always had in front. We had roving mics and question boxes that were always around where we could physically go to people, not making them come to us. We had educational materials available in the back as well as headset interpretations. So that way we could cover every single need. If we had something that came up during the meeting, I could show them like, hey, we've got a fact sheet that covers what Barb just said. This is what it looks like. It's on the back table, and somebody at that back table could lift it up and show them, and we could connect people really easily or bring the fact sheets to them. Now, that's great and all, but how did we actually do the verbal risk communication? It took a lot of preparation. So once we had our panelists finalized, everybody came onto a call, and we actually did some training of ourselves of what we needed to do to change the way that we were working and communicating with this community. The first thing we did is that we practiced having an improv mindset, which if you've never done improv, that means yes and. It's focused on finding the win and finding the what you can do. And it's the premise of not shutting down ideas, but instead collaborating and working together. Now, we've all worked on PFAS, so we know that it's really hard to say yes sometimes, and it's pretty easy to say no. So we learned how to say, we can't do that, and here's the reasons why. We can do this. Will that work? And we kept doing that until we could find the win, or at least say, we need to put a pin in this and see if there's something we can do. We also had to learn how to say I don't know, and know that saying I don't know is okay, which is really tough, especially as experts and also as government officials. There's a lot of pressure to always have that answer. But the truth is that credibility, respect, and trust is earned through transparency about what we don't know and where our boulders in the river are. And we're going to put a pin in boulders in the river. I'll get on to what that means on the next slide. But credibility, respect, and trust are foundations of effective risk communication. We had to do an emphasis on listening as well. Were we listening to respond, or were we listening to understand? With the community in the driver's seat having the mic, we needed to make sure that we were empathetically and critically listening to what they had to say. When we cycle through our own Rolodex internally of talking points as our response, we aren't listening to understand, we're listening to respond, and it can come across as disingenuous, and we have to learn how to balance what our talking points are and what we're allowed to say, and really being able to have a conversation with somebody instead of just giving what can come across as a programmed response. This community had expressed some frustrations about that, and we knew that we needed to do an emphasis on really listening to what they had to say. We also had to teach ourselves how to give the answer first and then the context. We had to answer yes, no, not quite, I don't know, and then provide why. But as scientists, we're trained when we look at scientific papers to start with the background, the methodology, the results, the analysis, and then the discussion where the so what comes the very last. But the truth is, when we're talking with people, we maybe only have 30 seconds of their attention span. If someone's feeling like we aren't answering their question, they might start to get frustrated, and that can shut everything down. So we had to learn how to do that first. And if having, the example of a scientific article doesn't quite resonate with you, I invite you next time you go and try and look up a recipe online, and you end up reading a blog about somebody's entire life story for 10 minutes before you can even get to the key ingredients. Watch how you feel in your body and see if you get annoyed or if you get frustrated. I would bet that most people are going to go, man, all I wanted was the recipe. That's very similar to what's going on for our community members. Now, pulling that pin back out of boulders in the river, this is something that Barb Morrissey, our toxicologist, came up with that I thought is a beautiful example of how you can support resilience through transparency when we're doing risk communication. The idea is, if we're all in the PFAS boat, us impacted community members, our partners, agencies, local governments, public water systems, and we are on the river towards community-centered, equitable solutions. That river has a lot of boulders, and those boulders could be the laws, rules, etc. that we must follow at agencies. It could be existing science or the lack thereof, the changing guidelines and regulations, or in the funding or the lack thereof. Well, we're all stuck in this boat together and we all need to paddle to get down the river. And if we don't communicate where the boulders are on our side of that boat, we're probably going to hit it and we are probably going to flip or we'll get stuck. And it takes every single person in that boat to be able to steer it. So if we can tell people where our boulders in the river are, then suddenly we're opening things up to being able to work as a team and being able to find solutions better, because somebody might be able to steer differently on their side of the boat. So getting into our non-acutely impacted Washingtonians, we do have our fourth activity for the day. So Jennifer is going to be putting this in the poll, but go ahead and answer your best guess. Awareness of an issue, good risk communication, and morality drive people to change their behaviors, true or false?
Okay, the poll is open. People can vote. Yeah, you just click on your screen. And this one, let's see, we'll let it go another few, let's see, 5 seconds. All right, I'm going to close this one. Thanks, Claire.
All right. The answer is false. We know from studies that people change their behaviors only when the benefit and or motivator outweighs the barriers to changing that behavior. And this is the premise.
A lot of people, yeah, 3/4 of the people thought it was true. Oh, boy, okay.
Surprise! This is why PFAS risk communication is so incredibly challenging. So one of the ways that the premise of this idea finds its root in the discipline of social marketing, which is kind of a weird term. So the hashtag for the entire discipline is behavior change for good. But the discipline of social marketing focuses on developing a strategic marketing mix to influence behavior change for sustainable, healthy, and equitable communities. It functions on the data-based premise that awareness does not lead to behavior change. Education alone does not change behaviors. People don't accurately report their behaviors related to social issues, and people do not change their behaviors because it is the right thing to do. People do change their behaviors when the benefit and or motivator to them outweighs the barriers to changing behavior, and this has been demonstrated time and time and time again. So there's 4 questions that make up the backbone of social marketing that our team uses, which is, do I really understand my target audience and see things from their perspective? Am I clear about what I would like my target audience to do? For my target audience, do the benefits of what I want them to do outweigh the costs or barriers to doing it? And am I using a combination of activities to encourage people to achieve that desired action? Now, when we are looking at our passively impacted Washingtonians, we can't necessarily go and have just a meeting with all of them and understand, oh, this is what you're going to need, because there's so many and they're in so many different areas of Washington and there's so many different groups that are impacted. So we needed to find a way that both met our budget and our capacity to be able to get a good pulse on what was going on for our larger Washington base. And we used a tool called market research. Specifically, we have a market research online community, or MROC, which is called Health Hub Participants. And this is run by our social marketing contractor, Kohler & Cohen, or C+C. Now, we started using this during the COVID-19 pandemic, and it was shown to be incredibly effective at helping us improve health outcomes across the state during the height of the pandemic through using social marketing campaigns. And so we knew that this was a tool that was incredibly effective, and we luckily were able to tap into it. Now, the MROC, the Market Research Online Community, is a recruited group of 645 participants that via C+C, we send agency social marketing studies to in return for a gift card. They're recruited by C+C, and that group is representative of Washington state demographics. Participants, one of the cool things is that they can be pre-screened into groups per the study's focus or aim, which is helpful because there's always going to be issues when you're doing a mixed methods or qualitative study when it comes to bias, when it comes to selection, when it comes to the generalizability of the data. And this is not statistically robust data. This is meant to give us a snapshot and maybe a little bit of an idea of what we might be running into when we go out into the quote unquote wild. But being able to screen into different groups and see if there's any differences between them when we're just testing something is really helpful. So we've run 2 MROC studies. One was in October 2022, And the latest was in June 2024, and these were the same cohort, but we got slightly different respondents to each of them, so we got a little bit of good variety. So for our October 2022 study, there was almost no data to go off of about general PFAS attitudes and awareness that I could find anywhere in the literature. And so we needed to get an idea of like, okay, so where are people at if we're starting on this? And the things we found is that, unsurprisingly, there was minimal knowledge and familiarity with PFAS, even when we told people it's the same thing as forever chemicals, despite how often it had been in the news in Washington recently. And people did notice that there was a greater knowledge of PFAS in products than the environment for the people who had heard of it. Mostly they knew that it was in nonstick pans and Teflon. There was attitudes of concern and confusion and sadness that came up when we were talking about PFAS, and that was really important to know because contrary to popular belief, we know from studies, humans do not actually seek out information to assuage their anxiety. They avoid it. And whenever we start getting those emotions like concern, confusion, and sadness, we have a very similar psychological process that makes us want to avoid the thing that makes us not feel great. And so knowing that just even learning about PFAS was bringing up those attitudes, even if they were unsurprising, gave us a cue that we needed to be very, very careful in the way that we framed our messaging. Otherwise, people might just shut down and ignore the message. We also noticed that among the people who were aware of PFAS, there was a really low knowledge of stopgap measures or short-term measures for lowering PFAS exposure in drinking water, like point-of-use filters. Most people thought you could either do nothing or install a very expensive whole house entry filter, and those were the only two options that you had. Now, we had 333 respondents to this survey, and there was no variance for us between our selected groups, which were Spanish speakers or people who are rural or urban. And about 12% of those respondents did know or knew someone who was or were personally affected by PFAS. Now, for our second study, which is the one we just did in June, we decided that we wanted to do a measure of trust in our health advice. And trust is really, really important, especially when you get into somebody deciding if something is true or false, because trust is one of the biggest predictors of somebody choosing to follow health behavior advice or actually changing their behavior. So we had 337 respondents to this particular survey, and only 6% of them knew someone who was affected by PFAS or were personally affected. And some things that we found were that when given asynchronously, like on a website or in a report or any situation in which that person can't come and talk to one of us directly, our standard PFAS information may not be providing enough basis for people to trust our health advice. This was especially true for dermal exposure, and we were finding this in our impacted communities too, where people would follow us on, oh yeah, so you don't want to ingest it, you don't want to breathe it, so don't drink the water. But when we would tell them, oh, by the way, you can still shower, they'd go, that seems absolutely backwards. What are you talking about? You just told me that for them, you just told me I have something that's toxic in my water and I'm supposed to let it touch my skin. And so that held true when we were actually doing this particular survey. We also found that we, being DOH or other health agencies, aren't the go-to for advice on PFAS. We asked people, who would you go to for more information on this? And they, above and beyond, said specifically environmental agencies that don't necessarily do health work, and also their municipalities. And so there was a disconnect, even though that they were being told that this is a health problem and this is a health concern and a public health concern, they didn't think to come to us. So we needed to understand better that, okay, we can't just do the anglerfish method on our website of put it out there and people will know to come to us. We really need to work on getting ourselves out in front of people more. We also noticed, because of high uncertainty in whether or not some of our standard health advice was true or false, even when given the standard PFAS basics information, that there were some possible issues identifying misinformation about PFAS. And we got to that conclusion by the sheer degree of uncertainty that people had about whether or not a piece of health advice was true or false. So just being aware, especially with the amount of information that's out there on social media and in news stories, that there might be some issues of people identifying something that's maybe not the best option for them to take. And all of this suggests that there is still low environmental health literacy levels, even if we had, even with all of our 2 years of work that we've been doing, getting our information out to the public. We did have a higher degree of familiarity with PFAS, which could have been a bias of this particular group, or it could have been some of the work of our program. So building up, what have we learned? And taking our little Tetris game, which is one of my favorites, and making sure that we are rock solid across our basis as we start building up. And one of the things that we did was we were told resoundingly by our community members for our impacted communities that they needed us to be way less governmenty in our risk communication. And so we said, okay, let's do it. And so we have two different approaches to that. One of them is we started a PFAS Basics YouTube series that gets into the foundational pieces of what on earth are PFAS, why are they a health concern, and what actions can you take to protect your health. And we also started TikToxicology, which is, I can't take the credit for that. A friend came up with the name at brunch and we kept it. And those are short little 90-second or less reels that we put out on Instagram, TikTok, Facebook, or LinkedIn, where I walk people through my day-to-day life and talk with them about PFAS as if I was talking to a friend. And that can connect them either back over to our resources that we have or over to a friend's resource. We recently started, based off of data from the CDC, a series of TikToxicology that's highlighting the work that our partners at local health, like Yakima Health District and Spokane Regional Health District, and our partners at the Washington State Department of Ecology are doing, so that people can get a better idea of how we're all fitting together. And for you guys, we're actually going to watch, we're going to try this. Jennifer, you'll have to tell me if the audio works. I'm going to show you a little clip of PFAS Basics video 4, which covers how to select point of use water filters or bottled water. So Jennifer, give me a shout out if this doesn't come up, okay?
Yeah, it's not quite working, the sound, unfortunately.
Okay. We'll go ahead and skip it, but I'll make sure that this gets out to everybody. Or if you want, I'll go back and you can go ahead and scan those QR codes, and they are live. But we have 3 new videos that are about to launch that are on consumer products and the safer products for Washington law that we have here in Washington State, and helping people understand the steps that they can take to protect their health. So thought that might not work, but so some tangible risk communication tools that we wanted to put forward that you might be able to use that our team has started employing over the last 2 years of our program. The first is gain-framed, positive, action-centered messaging. If you watch that video, you'll notice that everything we say is don't do this. We never say don't do this. Or if we do, it's only after we said do this action. It will protect your health. Just as I mentioned earlier, when people hear that negative framed messaging first, when they hear the scary thing, it triggers a similar chemical reaction in our brain to a bear in the woods. And our brain sometimes, you know, bless its heart, it's a bit of a binary creature. It can't always tell the difference between a real threat and a not real threat that just sounds scary. And so using gain-framed positive action-centered messaging is a great way to help people stay psychologically engaged in whatever the risk communication messaging that you're doing, and also help increase their self-efficacy and confidence in whatever steps they're taking. Now, I will say that the only catch to this that we know from data is that when you have an imminent, very real threat, let's think early days COVID-19 pandemic, when you're doing risk communication in those settings of a you must act now or bad thing will happen, that has been shown to be much more effective than positive action-centered messaging when you have that imminent threat. Another tool we use is that each sentence has a job in whatever material we are working on, whether or not that's a video, whether or not that's a reel, or whether or not it is a fact sheet. And that job is whatever our team has set as the objective of that fact sheet. And we get pretty harsh. We fire sentences, we fire words if it is not working to help us achieve our objective directly. So one way that you can also frame that is this nice to know, or is it need to know in order to take health actions or achieve the objective that we're trying to get with this fact sheet? So don't be afraid to cut sentences. Stephen King says, in order to be a good writer, you must kill your darlings, and everybody likes to overwrite a bit. So that's something that we've started doing, is viewing it as a job. We also do health literacy and actionability pretesting. And I'll get into actionability pretesting as an example on the next slide, but health literacy, one of the really simple tool to use is called a stoplight test, where you take whatever material it is that you're working on and you give it to somebody who is not at all related to PFAS, or they're one of your community members, and you say, hey, can you please highlight everything in green that's easy to understand, everything in yellow that you think you understand, but maybe not entirely sure, and everything in red that's really difficult. And then you get it back and you refine until you've got it mostly green. And that refine and implement loop is really important. We say that all of our fact sheets are fluidly published. But because of the really strong relationship we've been able to build with our community advocates, we can now say, hey, did this match? Did this not match? And when they come back and say, hey, we actually tried this and it didn't work, you know, I didn't quite understand that. We're hearing a lot of people are confused about this section. We can say, okay, cool, thanks for that feedback. And we can take it, we can update it, and then we can send it back out. So you are not your target audience, and you have to put yourself in your shoes. Just for the fact that you are the one making the fact sheet, you are not your audience. And this is what I mean when I say actionability testing. This was a fact sheet we had when I started in August 2022. And knowing that we had some pretty low awareness of point of use water filters, I wanted to see how well this actually worked. And so I went out to my local home improvement store and I took this with a big red pen and I tried to follow this step by step from start to finish to see if I could actually buy a point of use water filter. And the answer is I couldn't. This did not match the lived experience of actually trying to go out and shop for something. It didn't match the lived experience of trying to go online. And so I came back to our team and said, Houston, we have a third problem. This isn't usable. And we would not have known that had we not put ourselves out in their shoes necessarily, because we hadn't sought to try this. So what we developed was our new home water treatment for PFAS fact sheet. And this is above and beyond our most popular fact sheet when working with communities. And it's based off the lived experience of actually going out to a home improvement store or trying to shop for a filter online and the step-by-step instructions on what people will need to know and how to do it, including some pros and cons of the different types of filters that are out there, because it's not necessarily clear which one is going to work. And we do have a couple PFAS basics videos that are based on this fact sheet. Another tool or another thought I wanted to put by you is that just because it meets your agency standards does not mean it works for your community. This fact sheet here on the left was made for our West Plains community out by Fairchild Air Force Base and the Spokane International Airport. And the community had told us at their listening session that they were really concerned about cancer, and our epidemiology team started looking into it, and they wanted a report back of what we found. The fact sheet on the left checks every single one of our agency standards and was approved for publication. But when we gave it to that community, they went, we feel dismissed. This does not answer our questions. We don't even know. And we realized we had not actually been clear about what we had done and the way that worked for the community. And so we apologized. We thanked them for that feedback and we said, we're going to take this back and try again. And we worked with a set of community advocates on that fact sheet directly until we had it to a spot where they said, hey, I think that this is going to be better. Let's try it. And it's not quite perfect yet, but we are almost there. So some final thoughts for you as we wrap up today. Communities are not stakeholders when we're doing risk communication or any sort of PFAS work. They are in fact our most valuable partner and expert, because the people who are closest to the problem are the people who are closest to the solution. And that's important because communities that are part of crafting solutions and resources, including our risk communication, are more likely to use that solution or resource because it's going to be tailored to their actual lived experience in their lives. Trust and relationships are the cornerstone of that risk communication. Don't be a tourist. Show up consistently, and don't show up only when it works for you or when you need something. Make sure that you are available to them and you're truly along for the ride. And also, as I mentioned, just because it meets your agency communication standards does not mean that it's usable, understandable, or helpful. The only way we can know that if it is if we treat our communities as partners and experts in their own lived experience. And with that, I have to give a shout out if you are interested in hiring a health educator or somebody with a health education skill set. These are the 8 area of responsibilities that we function under as a discipline, and these will be on the slide deck for you in case you are interested in hiring them. So thank you so much for your time. I would be more than happy to take your questions.
Great. Well, thank you so much, Claire. That was a lot of great information.
Yeah.
So yes, there are definitely questions. How about the whole situation about virtual meetings? And can you do any of this virtually, or does it really need to be in person to be able to get those good interactions?
That is so dependent on the community that you're working with. And so because we're working with a rural community, we asked our community advocate, do you want virtual or do you want in person? And she said, oh, we don't want to do virtual. And that was emphasized by, I asked everybody what their social media was, and we had a gentleman in the front row hold up his flip phone. And that community, we also knew they had above and beyond been asking us for print handouts. But there's other communities that I've worked with where we've done things virtually. And that's what worked best. Either they had concerns about people getting sick by coming to a meeting, or just time schedule wise. So yes, you can absolutely do this virtually. I would say let your trusted community partner lead you on what's the best way.
So it sounds like a key component to all this is finding that trusted community partner, or, how does that happen?
Well, we got lucky that Brandy called us, and then she knew some other people in other communities who actually showed up to the first listening session. So we were able to, through our community members, make that network. Ways that you can find community partners is calling local organizations that are related to your issue. Local health often knows very well who everybody is in their community and who's on the ground. So we actually, one of our first calls was to our local health departments in the areas and said, hey, who do you know? Who do you know that you've talked to? Who's called you that we can talk with? And we networked through our partners. And that's where we can't do this alone. Everybody's involved. And so we worked that way. We do have some communities where it's been definitely difficult, but it's taken some just, working with the people who are local and on the ground to identify people or groups that we know are trusted, or even find the news sources that those people are a part of.
Okay. In a little bit different direction, what are some recommended ways to prep, internally your technical staff with communication best practices prior to public meetings or listening sessions, particularly the technical staff?
This is a really good question. And this is a really good question because it's definitely, I think, one of the key components of effective risk communication is making sure that your team is prepped. One of the ways that, I went about doing this was, showing our experts the data on health literacy that I was presenting at the beginning of the session, and said, hey, you're a data person. Data-wise, we have a problem. And data-wise, this is what I recommend that we do. And so I leaned on, for myself, I leaned on my literature really hard and said, okay, you're the type of person that's going to want to understand the why of this. So let me make sure that I'm doing my job to understand the why. And then came up with my recommendations to them, and we practiced it. And a lot of it is that you are the expert, and also to become that expert, did you receive training in how to actually communicate this? And sometimes that answer is yes, and sometimes that answer is no. And it's that, hey, let me show you the tools that you can use. And we've actually, like, for instance, Barb, I joke, is our other health educator, because she is so good at just being able to target health literacy at this point that I think having those tools, at least for our team, and being able to understand the why, that was really effective as far as prepping our technical scientists. But it's definitely can be a challenge. I hope that answered your question.
Yeah. Someone suggested another resource in the community for finding who to partner with might be a librarian.
Yes. Can you still see my screen, or can you just see me, by the way? I think I just stopped sharing.
We're just seeing you. Yeah, no more screen.
Okay. That's partnering with librarians, figuring out where your community is going, where those community spaces are, who's interacting with that community, and can be your cultural expert or your cultural broker, is super important. So there's definitely no one way to do this. It's going, okay, let me look at my community as its own individual ecology and figure out, where do people go? I've seen great things where barbers, very, very different word, where barbers were actually used to do health education because they were the person that everybody went to and talked to, and they were the most trusted source in that particular community.
Okay, here's another good question, and I think we're going to have to wrap up at this one, but I think everybody wants to know, how do you address, or how are you addressing the rapidly changing water quality standards for PFAS? Has this been a concern of your audience? Yeah, how are you communicating this? I know, state standards, EPA's got this proposed, state standards are here. Yeah, how are we talking about this?
Yes. That is a difficulty that, I spent an hour on the phone with one of our Office of Drinking Water experts yesterday, working on a fact sheet about the MCLs for water systems and water system customers. And so, a lot of the questions that we get is, why are there so many standards? And what the answer that we found is, the science is developing really rapidly, and regulations are based off of what we know. at the time, and we are finding out more as we keep going. And so I'd be happy to follow up with whoever asked this question digitally too, because this goes well beyond my expertise. But a lot of it is that, hey, we have new regulations based off the newest science that is more protective of your health. And that's the way that we've gone about communicating it. I will say the hazard index in particular is very difficult to communicate because of health numeracy issues. And so it's taken, I'm still working on a bit, making sure that we're tailoring to our audience and making sure that we've got messaging that is ready to be tailored for a multitude of different audiences. So like we might have slightly different messaging for our private well owners who it still gets the same core facts, but we've got, they're going to need different information than somebody who's a water system customer on this. But I don't know if that answered your question, but I'd be happy to follow up with you and chat with you about that, because it's something that we're working on. But yeah, it's definitely rapidly moving. What I will say is the focus on the so what, not the what happened.
Okay. Yeah, I think that's a more universal question. I know a lot of my states, also are wondering about communicating, the changing stuff. But I think a lot of people, a lot of the remaining questions are more about, you're awesome and your, health communication. This seems like a needed area, but yeah. Are there many people, and how do you find them, and how do you convince your boss that your organization should have one, and is there like a network of you all so that what you're learning in Washington is being shared across states, or how, yeah.
We're still working on how to share what we're doing across states. Doing webinars like this is just one of the ways. The Society of Public Health Educators, SOPHE, is one spot that definitely, is a hub for health educators. But going to the National Center for Health Education Credentialing, NCHEC, which is who I have my Master's Certified Health Education Specialist credential through, that's definitely one way to start. But as far as convincing somebody that this is important, I would just remind you that giving somebody information is not enough to make them care. It's not enough to show them that it's important. Data and figuring out the barriers is going to be really, really helpful. And sometimes it's something new. And sometimes people definitely need to see that it works. And I've been really lucky to have a team that has backed me up so hard on health education and really embraced this. So, but I would be happy to also connect with anybody that has those types of questions and offer what support that we can.
Great. So Claire is sharing her slides, which will have some of that contact information in it. And also, you might have noticed this session is being recorded, so it will be available later. So, if you want to try to show somebody what might be possible, you could have them try to watch the recording, or you could sit down together to watch it. And I think we're after 3 though, so we need to wrap up. So thank you so much, Claire. This was excellent, and we really appreciate, well, first of all, the work you're doing. A lot of other states are jealous that it's happening in Washington and not where they are. Yeah, this was so great. So I hope everybody enjoys the rest of your day, and we're going to end the webinar now. So thanks again, Claire.
Thank you.
Bye-bye.